Hello and welcome back to this Opinion Leader Workshop in non-small cell lung cancer. We're going to move away from adenocarcinoma now and move on to some of the non-adenocarcinomas in the non-small cell category, and maybe even a little on small cell. So Dr. Mark Chris from Memorial Sloan Kettering has come up into Boston for us to tell us what's going on in squamous cell and other cancers. Mark, thanks so much.
Well, thank you. Thank you for, again, giving me this opportunity. I guess the three of us here have been amazed over the last decade. I mean, we've just had the 10th anniversary of the discovery of the EGFR mutation in our institutions. It's just been an amazing 10 years. And hopefully we can talk about some newer developments here that will take those benefits to even more patients. I think we've talked about the traditional way of slicing lung cancers. Adenocarcinomas, squamous, and small cell. I think it's important here that adenocarcinomas are the most common, squamous next, and then small cell roughly 13%. People talk about a lot about why it's only 1% of adenocarcinomas. Well, please remember, this is just in the United States. 1% of adenocarcinomas is nearly 1,400 patients a year. So that's a huge number. I mean, how many people are GIST tumors? How many people have CML? I mean, this is really a large number of patients. Again, that's our traditional way of looking at lung cancers. I'm going to show you what perhaps would be our new way of looking at lung cancers. What we have here are oncogenic drivers in lung cancers, but all of lung cancers. This isn't adenocarcinoma. This is adeno, squamous, and small cell. These are extrapolations from the series done with those other types of cancers. But you see that our biggest nemesis is the KRAS mutation, EGFR sensitizing next, and the next is FGFR1, and we'll talk more about that shortly. But I'm hoping that this is where we're going, that there's going to be a unified approach to lung cancers, and we're going to be focusing more on the target than on any, at least for these targeted therapies, than any specific therapy. Why are these targets important? This is one piece of information from the Lung Cancer Mutation Consortium, and I'm showing this to say that when you have a population of patients that are defined by an oncogenic driver, and here are some of the common ones, you see very distinct natural histories. These are overall survival curves. These are treated and not, but each driver defines a specific history. And it goes from here a median of 4 years from the time of diagnosis of metastatic disease down to 2 years. With KRAS, for example. I'm going to talk a little bit about HER2. It's 2% of adenocarcinomas, and here it's more common than BRAF, more common than MET amplification, but still, again, about 2% of lung cancers. One other issue that has come up is this idea that only certain people can treat these patients, that therapies are not available to docs around the country and around the world. And I encourage you to go to this page of the current NCCN guidelines. What you see here is a list of genetic aberrations that have been found in lung cancer, generally agreed upon driver events, and individual agents that are available for lung cancer in the case of afatinib and erlotinib, and also for other cancers like cabozantinib, for example, approved in thyroid cancer. But this table is an example of how, when you find one of these drivers, you can use available drugs for other types of lung cancers and also for other kinds of cancers. And although hopefully some of you have found this helpful as we try to get approvals for these agents. And again, just to tell you that this can actually work, here's a script I wrote on April 12, 2012, vemurafenib. I wrote on there that this person had BRAF V600E lung cancer, and here's what happened with that. And this woman went on to have a 1+ year very nice response. And again, this was not part of a clinical trial. This was part of just writing that script that I showed you a second ago. The other issue that comes up is that folks say that, well, how can I find these aberrations? They're so rare. The testing is out of my league for one reason or the other. And what's happened now throughout the country, and this is information from our side. I know the Mass General has a very similar evolution, going from, I call it our now-gen system, which actually some people might even call next-gen, to a true next-gen system, an Illumina system here. So we are now routinely looking at 341 cancer genes at the start of care in our patients, not just in lung cancers, but other ones as well. The thing about this new platform is that in addition to finding point mutations, which the sequenome did very, very well, this testing system can also reliably find insertions, amplifications, and fusion genes. So in the time it would take to do FISH tests as well as mutational tests and sizing assays, this can do it all at once. And this is our current gene list, and this was developed by our investigators at MSK. What we see here are not just genes involved in lung cancer, but genes that our solid tumor specialists have felt have been important in a lot of different solid tumors. And all the genes we talked about in lung cancer are included in there. The other important thing, I know that most of us were celebrating Christmas, we may have missed this little paper, that the FDA has now improved a platform, in this case the Illumina's MySeq, for the development, for the use in testing in a multiplex fashion. And those of you that have carefully read the NCCN guidelines know too that even for EGFR and ALK, the testing is recommended to be done as part of a multiplex panel, both for ease of because of specimen issues, but also because of time issues. Obviously, you can't test one target after the other. You really need to get them all, and to get them early on in therapy. I think the message is that giving these drugs first is usually the best for the patient in terms of PFS and also in terms of toxicity. Again, this is not something that is done only at a few specialized centers. These are reports that actually, the first and the last, have filtered through me, filtered into my office, and people coming in for a confirmatory opinion. It used to be you get one gene sequence and the one on the far left is EGFR only, but now people routinely show up with a HiSeq platform-based specimen where, in this case, 200 plus genes were looked at. So HER2, something people know a lot about from treatment of breast cancer, gastric cancer, and also an emerging target in ovarian cancer, bladder cancer as well. In lung cancer, it's been known for many years that there are mutations in HER2, 2% incidence in the LCMC experience. There's another, and in that, another series from Fudan and Vanderbilt, also having a 4% incidence there, but also finding that half of their HER2 mutated cases were amplified. We have not found that in our LCMC cases so far. HER2 amplification is seen in about 2% of lung cancers, and that's a series that Maria Arcila and Leila Garcia put together, looking at our multiple genotype cases at Sloan Kettering and at Colorado. Here in Boston, Heidi Grulich has also described extracellular domain mutations in her that all show in part sensitivity to HER2 inhibition. And these, some of these mutations are the same ones that have been described in breast cancer as well. What you see there is data from Maria Arcila's paper about the kinds of mutations found. Almost all the aberrations are insertions in exon 20, and there are some point mutations as well, but actually been very uncommon in our, at least in our series. These are the agents that are available either investigationally or not, that have had, are being tested or have had some demonstration of activity in HER2 targeted, HER2 mutated lung cancers. Here's the waterfall plot for dacomitinib, a trial that many of us have been involved in. Actually, all the responding patients were cared for by, I think, patients, by physicians here today. Different kind of waterfall plot. Clearly some responders, and the two longest ones were a year plus, excellent response, minimal toxicity, but again, not that dramatic waterfall plot that we've been used to seeing from Alice with ALK and with Ross. But clearly activity there, and they're just to show that it actually happens. Now, I've been focusing on mutation in HER2. To the best of my knowledge, by the way, no one has reported a case of a HER2 extracellular domain mutation treated with any HER2 inhibitor. I haven't seen those reported yet. And now with next-gen sequencing, I think we'll be finding more of them. The other use of HER2 would be in lung cancers that have HER2 protein overexpressed or have HER2 amplified. And there are a number of agents that potentially could be used in that setting. This area has been studied previously. Here's some data that we had gotten from our patients from many years ago. About 15% of adenocarcinomas here had expression of HER2 at 2 or 3 plus using a standard assay. FISH detection really was not done at this time. And here's one example of some earlier trials done, 4 different trials, looking at the response of a chemotherapy plus trastuzumab in HER2 2 plus and 3 plus patients. And you see 2 of the trials showed a fairly high degree of improvement with the HER2 2 plus and 3 plus overexpressed cases compared to not. The other ones did not. I should also mention in the Gatzmeier trial, there was some very intriguing data about the HER2 amplified cases having an increased and durable response to trastuzumab plus chemotherapy. And here's an example of trastuzumab and paclitaxel, one of the reported in the New England Journal of Medicine. This patient, in addition to having HER2 amplification by FISH and HER2 overexpression, also had a mutation in exon 20 of HER2 and a nice response seen. So we've told you hope a compelling story for defining adenocarcinomas by oncogenic drivers. That's that top pie over there on the right. But now we want to take this on into the other kinds of lung cancers. And at our institution, we have developed specific programs to look at squamous cell and small cell. This is data that Paul Pack presented at the ASCO meeting almost 2 years ago now, where we took patients that had squamous cell cancer and ran them through our testing program. Using, I'll call it our now-gen sequencing, our current sequencing, you see that in about half of the cases we found an aberration in squamous cell, FGFR1 amplification, PTEN loss, PIK3CA mutation, in one case of a RAS mutation. And the majority of cases, though, we did not find a driver in that system. All were mutually exclusive, and again, 46% had a driver. These drivers are important because there are agents not available, but generally in clinical development that can be used for them. And already there have been reports that using the agent BGJ398, a PR has been found in a patient with FGFR1 amplification, and also giving dasatinib to a patient with a DDR2 mutation had benefit as well. So as you can gather, we've moved from our now-gen to our next-gen platform. And this is an example of how much more you can learn there. So in addition to finding FGFR1 amplification, PTEN loss, which was again done by IHC, PIK3CA mutation, we also found mutations in PTEN. So now we potentially have almost 2/3 of the patients with a targetable driver here with squamous cell cancer. We've done the same thing with small cell, more preliminary data. This is data that Kathy Piatanza presented at the ASCO meeting in 2013. And even in this very preliminary data, the first thing is it's put the lie to this idea that we have no tissue in squamous cell cancer. These were not people that were specifically chosen for this. They were people that walk in the door that had enough tissue for this. And we were able to complete this next-gen platform with as little as 15 nanograms of DNA, which is really a tiny amount of material. We found actionable amplifications in FGFR1 and MET. We also found that common mutations that we know occur with small cell, actually the sort of signature mutations in P53 and RB1. We found some additional amplifications as well. So I think in both squamous and small cell, our current multiplex technology can help us find drivers that are clearly actionable, and some of them could be actionable even with drugs that we have available in the clinic. Moving on. For over 100 years now, people have looked to using the immune system and trying to find a way to overcome the evasion of the immune system by cancer. And many of you saw the last issue of Science in 2013 calling cancer immunotherapy the breakthrough of the year. Now, Generally, we have learned so much from our colleagues in the melanoma area that have focused on two classes of agents. Drugs that can, I'll say reactivate, though that's not precisely correct, the T cell that has been downregulated or turned off by cancer. And those are drugs like ipilimumab, affecting the target CTLA-4. The other group of agents are, and this is again on the T cell, the other group of targets are on the tumor itself. And that PD1 and PDL1 on the tumor cell can actually cause the T cell activation to be suppressed. And in that way, evade immune surveillance. So the term that people are saying is the decloaking of the tumor that can happen by giving an antibody against PDL1 on the surface of the tumor. And these are the two strategies that people are looking at: anti-CTLA-4, like ipilimumab, and then anti-PD1 and PDL1 therapies, which I'll go through in a second. I think at ASCO last year, we were all very excited, again from the melanoma area, about using drugs that target both of these, using agents targeting both of these strategies and using them together. And very impressive data was shown last year in malignant melanoma, combining ipilimumab, anti-CTLA-4, with nivolumab, anti-PDL1. What I show here is the current list and scorecard, as you will, for immune checkpoint inhibitors under study in lung cancers. You see it's a blessedly busy and crowded field. We have multiple agents targeting PDL1, PD1, and CTLA-4. And all of these agents are currently in trial or have been in trial in patients with lung cancers. As you see, the ones that are farthest along into randomized comparison trials would be nivolumab, MK3475, and MPDL32808A. Ipilimumab by itself, also in trial as an adjunct to chemotherapy in a number of different cancers, and the combinations as well, and I'll show you some information on that. So here's an example of some patients treated at our institution. And I think the most striking observation is this, and this is a spider plot. Again, below that middle dotted line means that the cancer is shrinking. These agents first came in as phase 1 agents, so people had had all their standard therapies before. And what you see there are, number one, a number of responses somewhere in the 30% range, and number two, responses that are durable, and those are patients, again, remaining with disease under control for well over a year or more. Shown here is some waterfall plots looking at anti-PD1 and PDL1 drugs as monotherapy or in combination with bevacizumab, with ipilimumab, with chemotherapy. And I think here again is the consistency of the activity of these drugs and their ability to work in concert with other therapies that we have. I think the bottom line on giving nivolumab and chemotherapy, that giving the two together is clearly more toxic and indeed may make more sense to use these drugs sequentially rather than together, and I think that's one of the things we've learned here. But I think what we see here is no matter what the agent, and using immune therapies together or using them with chemotherapy, a consistent response, and particularly response as monotherapy. You could question whether or not those chemo responses were really chemo. They look a little bit robust, but we could argue over that. But clearly these responses to monotherapy are that. And also they come in patients, by and large, that had already seen all the best we had to offer and really didn't have another option. So I think we're looking to these drugs as a great way to add to what we have right now. This idea of matching agents to drivers in squamous cell carcinoma is taking a national leap forward as well. This is the so-called master protocol being developed by the Southwest Oncology Group. And the plan here is to take persons with squamous cell lung cancer, genotype them up front, and where a A target could be found with a matching agent, and these are the targets you see there: PI3K, CDK4, FGFR, and HGF. A targeted therapy will be given to patients whose tumors have that target. For those where there is no match, the non-match there on the upper right, those patients will receive a anti-PD-L1 agent, the MEDI 4736. So this idea of treating squamous cell cancers in this targeted way, matching drivers and targets, is moving to squamous cell as well. And I'm sure you're going to see a similar thing with small cell very quickly. So I hope to leave you with this thought that we need to rethink lung cancers. In truth, it is sort of one disease, and we can use these drivers as a way of subdividing lung cancers into meaningful categories, both in terms of estimating prognosis and in terms of defining treatments. I think also we're over the day now where agents that are developed for a target should be given to other people with lung cancers that don't have that target. That makes no sense. And also ASCO has recently come out in this area, looking at those things we can do in oncology to improve our care. And one of them is to give targeted agents only to people whose tumors bear that target. We need to think of lung cancer as one disease in terms of the need to genotype. I think we've seen that there is no profile and really no histological profile that will tell you exactly what kind of lung cancer you're treating. You need to do genotyping. And also with the widespread and availability of multiplex genotyping, we can get these results and get all the results on an individual patient and get it in a timely way too. And just to tell you how quickly this field has been moving, I gave a talk back in 2005, and one of the physicians in the room sent me this cartoon. It's a woman going to her druggist and handing a prescription saying, here's my sequence. I'm showing you there that prescription I wrote in 2012. I wasn't thinking of that cartoon at the time, but it's exactly what that cartoon said might happen, and it actually did.
Very good. Thanks, Mark. That was very interesting. So we'll take a little break now, and we'll come back and we'll discuss some cases and ask some questions that will hopefully help you in your management of your non-small cell lung cancer patients in your own community. Thanks again.